go ahead.
Hello, all. Good evening, everyone. Welcome to the third series and third edition of Tenacious Tuesday Teaching. Topic today is actually two case presentations. First is on diagnostic formulation, and the second one is on examination and management. To introduce our experts, we have Dr. Nimesh Parikh sir and Dr. Mathili Umate ma'am. Dr. Nimesh Parikh sir is professor and HOD Department of Psychiatry, NHL Medical College, Ahmedabad. And sir is also EC coordinator for PG Psychiatric Education Committee. Sir has been past president of IPS Gujarat State Branch. Major achievement of sirs were many publications in various different journals. Sir has also published awareness articles in Divya Bhaskar. Sir has given various talks on public and institutional platforms on the stress management, defenses, and maturity. Sir has also been examiner for multiple batches at various universities. Incidentally, sir were my examiner too. Our another expert is Dr. Maithili Umate ma'am. Ma'am has done MD, DPM and DNB from SAT GSMC Mumbai. Ma'am's MBBS was from TNMC Mumbai. Ma'am is currently at JJ Hospital and Associated Medical College as Associate Professor. Ma'am is also Joint Treasurer of Bombay Psychiatric Society and Chairperson of Research Committee IPS Virson. Ma'am has won award for Best Lecturer in 2014 and Excellent Services in 2020. Her areas of interest are forensic psychiatry, women, and mental health. I now invite the experts to introduce the topic of diagnostic formulation, which will be presented by Dr. Neha Patel. And then following that, we would have Dr. Rashida Pinto's examination and investigation case.
Thank you, Nachiketa. I think we can start with the first speaker, Dr. Neha Patel. She is from Sion. I understand that. And she will present the case, which is for the total history and diagnostic formulation. So we'll try to find out any problem with the history and MSc and the diagnosis. We'll not go for management for this patient. And the next one, we'll try to go for investigation and management. Okay. So I think she can be given 12 minutes to present her case, and then we'll have a discussion and other things for that. Okay, so we can start with Dr. Neha Patel.
Okay, Dr. Maithili, if you have to say anything.
Yes, madam. If we start with the first candidate and then we can go ahead with the discussion.
Okay. We couldn't hear you earlier, so.
I was having
Yeah.
problem with the earlier laptop, so I plugged in through the phone.
Okay, great. Good to see you here.
Thank you, ma'am.
Dr. Neha, please unmute yourself. Dr. Neha?
Yes, sir.
Yeah, so I will be sharing the presentation. You can start with the case. Is it visible?
Yes, sir.
Yes,
Okay.
it is visible.
Good evening, everyone. I'm Dr. Neha Patel, a JR3 from Sion Hospital. Today, I'll be presenting a diagnostic formulation based on a case history. So, should I start?
Yes.
Yes.
Please start, Neha.
Okay, ma'am. Mr. X, 30 years old, right-handed, married Muslim male, belongs to lower socioeconomic status, educated up to 12th standard, not currently working, resident of Top Hill, Sion, brought by wife and brother who are adequate and reliable informant to OPD with complaints of irritability, angry, abusive behavior, big talks, more talkative than usual, overspending behavior, decreased need for sleep since 10 days, onset, course and progression. Onset is insidious, course is episodic, and progression is deteriorating. This is second hospital admission of patient. History of presenting illness is patient is known case of psychiatric illness. was well maintained on medication. He stopped taking medications 12 days ago following demise of his cousin. After that, his family members noticed change in his behavior in form of claiming great authority, having great wealth and powers. He would believe that he is Badsha and having a lot of money and all the people are below him. He would be saying his family members to leave their job as he was offering them 2 lakhs each. Wife also complains of easy irritability, angry or busy behavior. He would get irritated even after a minor provocation. Few days back, he told his brother to get haircut, which he refused. Then he started beating him up and started saying, I'm Badsha and you can't defy my authority. He started spending a lot of money on things he would not need. Over the period of 10 days, he had bought 4 to 5 pairs of shoes and kurtas and spent around 20k rupees. He would randomly distribute money to strangers. That is highly unlikely behavior of him. On asking, he would say, Allah ki bahut meherbani hai mujh par. He wouldn't sleep more than 3 to 4 hours in night and remains active whole day. Today morning he went to mosque for prayer. There while praying, he went to Molvi and said him that you are reciting Quran in wrong way and started verbally and physically abusing him. For these complaints, he brought to Stan Hospital. So next slide.
Yes, it is
Past
there.
history, patient was apparently all right 4 years ago. Then due to financial stressor, as he had to pay home loan of 1.5 lakh and responsibility of other family members, he had complaints of irritable, angry or busy behavior, anger outbursts sometimes, big talks, excessive talking, decreased need for sleep. For these complaints, patient was admitted in San Hospital and treatment was given in form of medications and 6 ECTs as per OD. Improvement over 1 month has been seen and continued his treatment on OPD basis. Patient was well maintained on medication till 2020 when after unemployment due to lockdown, he started feeling sad all the time, withdrawn behavior, lost interest in previous pleasurable activities and couldn't able to sleep and started voicing death wishes. Family members took him to psychiatrists and made change in his medications. Patient improved or 2 to 3 months and well maintained, was living his normal life till current episode. Negative history, there is no history of substance abuse, no history of any psychotic features, OCD, anxiety and phobia, no history of self-harm, there is no history of head injury and seizure disorder, and there is no history of any other medical and surgical comorbidity. Family history, history of bipolar disorder in father taking treatment from Sion Hospital, history of suicide in his paternal uncle, details are not available. Personal history, birth and developmental history not known to ODs. Education, studied up to 12th standard, was average in studies, dropped out due to financial conditions. Occupation, patient earlier used to work as tailor, then worked at garment store after unemployment and was regular at work. A patient is not working since 20 days. Social history, patient is third born out of 8 siblings, married 6 years ago, non-consanguineous marriage, arranged marriage, currently living with parents, wife, 3 children, and one divorced children with 3 children of her. He is sole breadwinner of family, financial stressor present, and there is good social support. Forensic history, there is no history of conflicts with law. Pre-morbid personality, his predominant mood was tense, calm, and worrying in nature. Social relations, good interpersonal relationship with friends and family. He used to do watching TV, spending time with friends in his leisure time. He is responsible, his poor coping skills and poor frustration tolerance, and religious. Fantasy life not reported as per patient OD, and habits, fair sleep pattern, and appetite. On general examination, patient is average build, well nourished, kempt, and GC is fair. There is no history of pellar, icterus, sinuses, clubbing, lymphadenopathy, and edema. Patient is febrile, pulse 80 beats per minute, BP 130 by 80 mmHg on sphygmomanometer, SpO2 99%. Respiratory rate is 18 per minute. Systemic examination on CVS, CNS per abdomen or respiratory, there is no significant finding found. On MSc, a conscious, cooperative, and communicative young male, well-built, kempt, bruises or hands and forehead, wearing goggles and lot of rings in both the hands, patient restlessly pacing around in OPD and getting irritable in between the interview. Psychomotor activity increased, eye-to-eye contact initiated and maintained, attention active aroused, ill-sustained, and passive attention is increased. Repo established with difficulty, mood being labile, affect irritable and not appropriate to surroundings, speech spontaneous, continuous, coherent and relevant, pressure of speech was present, rate, tone and volume was increased. On thought, there was delusion of grandiosity in form of identity and ability. That is, मैं बादशाह हूँ, बस सब मेरी बात सुनते हैं, मेरे पास शाही खजाना है. He denies any sensory modality. On concept, intact, both simple and abstract, oriented to time, place, person. Memory was intact. Judgment, personal and social judgment was impaired. Intelligence, average, and insight, grade 1 out of 6. Now we move ahead to diagnostic formulation. Mr. X, 30 years old, right-handed married Muslim, belongs to lower socioeconomic status, educated up to 12th standard, not working currently, resident of Antop Hill, brought by family members in OPD with complaints of irritability, angry, abusive behavior, big talks, more talkative than usual, overspending, and decreased need for sleep since 10 days after stopping his medication because of demise of his cousin. Patient was diagnosed at bipolar 1 4 years ago following financial stressor, was admitted and started on medication, and 6 cities was given. Patient was improved and well maintained till 2020 when, after losing his job, had one episode of depression. Medication is given, was improved and well maintained till recent episode. History of bipolar disorder in father taking treatment, and there's history of suicide in paternal uncle. On MSc, patient is restlessly pacing around in OPD, getting irritable in between the interview, psychomotor activity increased, active attention was present and ill-sustained, passive attention increased, mood being labile, pressure of speech, and delusion of grandiosity in form of ability and identity were present with insight 1. As per DSM, my diagnosis is F31.13, bipolar disorder, currently manic episode, which is severe. And according to ICD-11, 6A60.0, bipolar type 1 disorder, current manic episode without psychotic symptoms. As per 4P model and biopsychosocial model, predisposing factors being a history of bipolar disorder in father and suicide in paternal uncle. Precipitating factors are financial condition and demise of his cousin and poor treatment compliance. Perpetuating factors are ongoing financial problems, and protective factors being good social support, absence of DSH attempt, and absence of substance use. According to biopsychosocial model, biological factors being family history of psychiatric illness, psychological poor stress tolerance and coping mechanism, and social factor being financial stressor. As per management, I would like to hospitalize the patient and will send all the routine investigations. On short-term plan, for pharmacological plan, I'll start on patient on tablet olanzapine 5 milligram BD and tablet divalproate 500 milligram BD. Is
Dr. Neha, we can
patient is
skip it.
already was tablet.
I think management part is still
We can skip.
wait for that. Yeah,
Yes, sir.
Okay, sir.
we can discuss with the
So
history
should be the
and
concluding.
diagnostic formulation in this patient.
Yes, sir.
Yeah. So if she is Dr. Neha, if you have completed, then we can discuss out the thing for that.
Yes, sir. I'm
Yes,
done
sir.
with
It is
history and diagnostic formulation.
So, okay, very nice presentation, Dr. Neha.
Thank you
It is
so
very well. 4P model is very much relevant in diagnostic formulation. You're done. The things which we would like to say, which we can improve in this history and diagnostic formulation, we'd like to talk about that. If you go with the first slide. First one.
So the first slide.
Yeah. So whatever you have said, the OPD means present illness complaint, whatever you have mentioned, I think at
Yes.
the same time, you can mention the all the positive features which is there. With that, every features duration and progression, if
Okay, sir.
possible. You have tried to give one sentence for each symptom, but it can be a little bit more comprehensive to understand that patient's ODP. If we go with the second stage, yeah, second slide.
Slide.
Yeah, so what we understand that you have mentioned the symptoms, but that is like there is no chronologicity is maintained. That first what happens in 10 days before first symptom, then gradually which symptom develop in the gradual way, what symptoms is now since last 2 days. Suppose irritability is there, which is since last 2 3 days, or it is since 10 days. So that can be a one comprehensive view about the symptoms chronology, which you can mention here.
Okay, sir.
Yeah, you can understand, Dr. Nia. If you see the slide, you have no mention about the symptoms chronological ordering.
Okay.
Okay. So we can try for that. For every student, we want that always the patient's history should have a first one symptom, then second, then third, and then there may be the symptom which needs acute admission from the family member. So if we can present well like that what happens first, then what happens second, that may be better idea for patient. Here also you mentioned that about the spending money, grandiosity, and yeah. But then
Okay.
next slide, yeah, next
Yes,
slide.
sir. Yes, sir. Past history.
So suddenly she came to the past history before she has completed the ODP in a proper way. Suppose she has not mentioned about anything about the sleep in this present history. What happens to her sleep pattern? Okay. What happens to her pressure of speech or flight of idea is there or not, or whether patient is irritable since 10 days or 2 days or whatever different things. Okay, and then what are the negative points in the present history? That should be, I think we can present with that ODP only, that at present in ODP there are no this thing, which I think she has mentioned after past history. If we go through the past history, and then she start with the negative history. So that negative history is for 4 years or it is for 10 days, means it is for present illness or it is for the whole 4 years of the total illness, what she is talking about. That is not clear. Okay, and she has also mentioned no history of psychotic features. But at the same time, she has mentioned in the history that patient is having a grandiose delusion like things, that he is saying that I am Basha, and if somebody is not obeying him, he becomes very much irritable. So it is like a delusion of grandiosity, which she has also mentioned in MSc. But at the same time, she is saying no psychotic features. What we are saying, okay? So I think that are the little things which can require a correction if we want to present comprehensively. I think Dr. Neha got it.
Yes, sir.
You have mentioned no psychotic features, but there is a psychotic features.
Yes, sir.
Delusion is there or not?
They are there.
Yeah, so that's what we have to try to see, that present history, you can mention the negative history about the present illness, and then you can mention the past history. Okay, if we go through the past history again, you have mentioned past history, but that should be possibly, we required a graph like what you have said here. It is not
Yes, sir.
very clear that it is a manic episode first time, but second episode is manic or depressive. That is not clear here.
Okay, sir.
So if you make a graph like what we generally mention, I think Cyan also, everybody as a teacher, they are very competent and they have taught you that The graph
Yes,
for
sir.
the
Like,
first, yeah, life, that first is manic episode, then for how much months she is all right, and then again she is in down depressive, then again she is all right, or he is all right, and then he is going manic. So if that graph is attached, that is very much relevant in the past history.
okay, sir.
Okay, so that's what minor things we will try to see in the history part, what you have tried. The next slide, what we go through that, and we'll see that what we can improve in a way. Then family history, you said that father has a bipolar illness, and then his paternal uncle has a suicidal history.
Yes, sir.
Okay. But then as a management line, you are saying that patient should be, we should start with valproate.
Yes, sir.
So we can discuss with that afterwards in management, but that is the point you should remember, that strong family history. Okay. Then next slide we have mentioned about the MSc, I think.
Sir,
Yes.
personal history.
Personal
Personal
history.
history.
Personal history is okay. We understand that is no problem with that part. Only we can manage something about the sexual life of the patient. If there is any current change in that or not.
Okay,
If
sir.
you ask that, it will be a good, because there is no sexual life is mentioned in a way. Okay. And next one. Yeah, that is all good. Pre-morbid general examination. The next one. Okay, in MSc, that is very good, but only thing I understand that speech, what we understand, we teach to our resident is that speech comes after the behavior, and mood and affect comes afterwards, which you have said that first you have mentioned mood and affect, and then you go with the speech. Okay, and also in mood and affect, there are so many things we can mention. Mood
Yes,
is
sir.
confident or not, affect is irritable, but it is also appropriate to the situation or not. What is the range of affect? So many things we can mention. So you very, very simply write down like a OPD patients, what we can write down here, not as a very clear presentation for the long case in the exam or the indoor setup. Make that very clear. Mood and affect should be very clearly mentioned, detailed.
Okay, sir.
There are different things which can be mentioned in the affect and the mood.
So I
Okay.
would like to add one thing. So in the previous
Yes.
slide, the
Yes.
MSc first slide of MSc, you have written he's conscious,
Yes, ma'am.
cooperative, and communicative. And then you're also mentioning he's pacing around, he's irritable, and rapport was established with difficulty.
Yes, ma'am.
So you're saying that he's cooperative, and then you're saying he rapport was established with difficulty. So that doesn't match really.
Okay, ma'am.
So that is again in that slide, the affect she has said irritable. That is also, we generally don't mention affect is irritable. I think affect is a broad and congruent with the mood. Mood can be irritable and labile both. And affect can also be labile if you want to say. Affect irritable is not a very usual terms we use in the patient in a way. Okay. I
Yes,
think
sir.
Dr. Janvi or Maithili can also highlight the issues, whatever she think.
Sir, can I also say something here?
Yeah, please.
Sir, she has written psychomotor activity increased. So
Yes,
I think it can be elaborated in
yes,
MSc.
yes.
Because whatever she saw as increased psychomotor activity, maybe that can also be elaborated. So
Yes.
we know what she means by increased psychomotor activity.
Yes, and she can mention there is a pressure of speech, but she has not mentioned there is any clang association or not, which we find in the manic patient generally. If she is acute manic, then there may be a clang association also. So she may mention here positive or negative, that is there or not. Okay.
Yes, Maithili, you were saying something.
No, I mentioned about that. Yes, so far I think sir has covered most of the point.
Yeah, we are
I
trying to
mentioned about
improve
the.
the things. It is okay.
Hmm.
She has done very well, good efforts, very good efforts. But what we want that there should be more comprehensive MSc and detailed workup should be required for that to mention. That's what I think. Next slide. Yeah, here already she has said delusion of grandiosity. She has mentioned very clearly, but
It's like
yeah, but she can try to elaborate that more. And in thought also, some other things like suicidal idea is there or not, or homicidal idea is there or not, that can be mentioned as patient is irritable and aggressive. We can mention that two things always in the thought process. Understand?
So,
So I
so
think
one more
that
thing.
is, yes.
So one more thing, the concept she's put it later. If she could include it, the concepts with thought. The perceptual
Concept means,
abnormality came earlier.
yeah, really thought that she has to divide that into four things like what we say form and stream of thought and content of thought and possession. If she can write down four things in a way that there is no formal thought disorder, there is no stream, there is any problem or not, and then content, there is this thing, and then possession, there is no abnormal possession in the thought form, then I think that will be giving more comprehensive idea about thought. And concepts, I think it is an abstract thinking capacity what she is talking about, which is comes in intelligence. After that, I think. So memory, judgment, intelligence. So memory, then we have a intelligence, then judgment and abstract thinking capacity, and then insight. Okay, so that can be okay. There is little bit more comprehensive ideation or work should be done by the on her side for a presentation. If she is presenting in the long case in the exam or in the indoor setup. For OPD base, this history is okay, but not for the indoor patient or for the exam point of view, what we can discuss about that. And then we go with the diagnostic formulation. Next slide.
Yes, sir.
Yeah, she has mentioned the positive points in the diagnosis. That is okay, but then she has not covered all. If we want diagnostic, we require that how many symptoms are there, which she has not tried to clarify. In diagnosis, what generally we want, that patient is having 10 days complaint of these things like talkativeness, then hyperactivity, then having grandiosity, then having talking more than usual one topic to another, then having impaired judgment or like spending money without any restraint or whatever. And then there is no this thing which is mentioned as per the diagnostic criteria either for ICD or either for DSM. So that gives the idea that it is a severe or it is a moderate or it is what type of symptomatology he had. Okay. Yes.
Maithili ma'am, any inputs?
Yeah. In the previous slide which she had, yes, as sir said, she can include more of the symptoms which will fulfill the criteria. Additionally, also in the depression thing, not just in diagnostic formulation, even in history, the symptoms were not mentioned clearly. If she could have elaborated then and mentioned how many symptoms, it would be better.
Yes.
The
And the
depressive.
next, yes, depressive symptoms. Yes. And then in next slide, what she has write down without psychotic features. That's what I think is ICD. She has write down manic episode without psychotic symptom. And she has said in MSc, there is a grandiose delusion. Dr. Neha, you are agreeing with your diagnosis? and your MSc finding?
No, sir, there is a mistake from my side. It should
Yeah.
be more congruent psychotic features.
Yes, and that is also in DSM-5 also you can mention same thing, that it is a more
Yes,
congruent
sir.
psychotic features. Or otherwise, if you say it is without psychotic, then you should mention in MSc that it is not a delusion and it is only idea level,
Okay,
if
sir.
it is there. Understand? You have to make the things comparable. Means it should be synchronous. MSc and diagnosis cannot be a separate entity. Okay, it
Yes,
is
sir.
going together. So whatever you say in MSc, that should be reflected in your diagnosis.
Okay, sir.
Okay, so that are the few things which I think every resident should try to understand and include in their exam presentation of the long case. And MSc should be thorough. And whatever the diagnosis based on MSc, the positive points, summary, or diagnostic formulation should include that. Okay. Yeah, these four P's are very good. That is really a good understanding about the predisposing and precipitating and other factors which we can try to understand in management line. That is very good. Any questions or any comments from Dr. Shilpa, Dr. Maithili? I think they can, or Dr. Nachiketa, whatever.
Yes,
Sir, if
sir.
I may. Okay, ma'am. Ma'am, please go ahead.
Yeah. It is explained very well because it is very important to understand these 4 Ps because they help not just in understanding the illness, but also in terms of the treatment plan. It is very comprehensive and useful. So everyone, all the residents should be paying attention to these 4 Ps. Yes, Dr. Nachiketa?
So I would be asking something on behalf of all the residents and myself. Here we have diagnostic formulation. Now, one common dilemma is whether to use technical terms for the sake of concise and brief presentation or not.
Yeah, I think diagnostic formulation should use the technical or psychiatric terminology as far as possible. We can use even the patient's adaptability, adaptive skill. We can also use the patient's present defenses, whatever she is using. We can also use to say that what is the, if any genetic loading is there or not. So that all can be included in diagnostic formulation along with the present symptomatology and signs.
Maithili, ma'am.
Yes, I agree. There should ultimately the diagnostic formulation is leading to the diagnosis. So it is useful to consider the diagnostic criteria because it becomes clear that how many symptoms the person is having. So it equally becomes clear that if the current symptoms are mild, moderate, or severe. So using it in that formulation would be much better. Whereas putting using the general terms would be helpful in a diagnostic summary rather than a formulation.
Yes.
Shilpa, ma'am.
Yeah, so I just wanted to add that means that what both Dr. Parikh and Dr. Maithili said, Neha, if you could put it in a way that would be more comprehensive based on the criteria. So
Yes,
because
ma'am.
so whatever you have written in the diagnostic formulation in terms of history could also be a little more concise, that presence of these symptoms for whatever number of days, in terms of whatever psychiatric terms that could be used, in terms of either mood or increased spending or in decreased need for sleep. All these technical terms can be used. And also on MSc, whatever is present and present for whatever number of days. And whatever is not there also can be said. Because if you have 3 out of 7 symptoms or whatever is the criteria, then you have already established that. The examiner doesn't have to ask you separately why you're calling it a meningitis.
Okay, ma'am.
So you can use those technical terms in history as well as MSc to establish the diagnosis. That is what we are trying to do here.
Okay, ma'am.
Yeah, and also we think that whatever you mention in history, that only comes in diagnostic formulation. Like you have not mentioned decreased need for sleep in the history. That is not explain anything in the history. Decreased need for sleep is, if it is not mentioned in history, you
Sir, it
cannot
was one of
mention
the
in the
presenting
diagnostic
symptom.
formulation. Yeah,
Sir, it was one of the presenting symptom.
but that should be explained. If she has written
Yes,
down
sir.
decreased need for sleep, what do you mean by that? Patient has said, I
Yes,
have
sir.
decreased need for sleep. Then she has not explained that in the ODP, that present
Yes,
illness.
sir.
If you go through that whole, she has not mentioned anything about that, what patient has, what hours of sleep he is taking, what he is complaining, how she has established that it is a decreased need for sleep.
Yes,
Understand?
sir.
So it is like a textbook criteria just to copy paste. That is not the right thing. We have to put that into the patient's history clearly, what the patient has that sleep problem, and how we can establish that it is a decreased need for sleep. Here she has said he wouldn't sleep more than 3-4 hours and remains active. That only she has written down. But only that thing is sufficient to say that it is a decreased need for sleep. So I think that requires something more. What ODP, every symptom should require some detailed workout. Okay, how much sleep he was taking before, then how much he is going through now having sleep problem, how many hours he is getting sleep at present, and what complaints he had after waking up. He is complaining or not, only the relative complaints or not. And if we ask the patient that if he has less sleep, then what is the problem with him, then he said that I don't have any problem, I'm happy with only 3 hours of sleep. So all that should be established in the history to understand and put that as a decreased need. Okay.
Yes, sir.
Yes. Anything next? What any chat or any questions came from any person?
Yes, sir. There are few comments from Nilima ma'am. Ma'am has mentioned
Yes.
about the abstract thinking and about the diagnosis of mood congruent psychotic symptoms rather than absence of psychotic symptoms.
Yes,
And
yes,
then,
that's what we have think. Yeah,
yes, sir. Yes, sir. That part has been covered.
yes.
And Sri Lakshmi ma'am has asked to the experts if you could provide an example of how an ideal diagnostic formulation should be written for this case.
Yeah, we can give the brief outline because every case requires something different. We cannot put a very copycat type of diagnostic formulation. But what we want is the present history and MSc, positive features and negative features should be mentioned. Then there should be mentioned the genetic loading, if anything, that can be, here she has made that father as a BMD, but that should be genetic mode, what we want to say. Then we can mention the patient's adaptability and social skill, what we can mention about the pre-morbid level and what is the present level. We can also mention the patient's ego strength, and if possible the defense is the what a patient is using. It is psychotic, so we can use that patient is using denial or projection or whatever different defenses what patient is using. And ultimately we can mention the uh, diagnosis based on these all things together, along with the what 4 P's she has said: predisposing and perpetuating and other factors.
Maithili ma'am?
Yes, why the question was the earlier slide can be shown? Like they were
Yes, ma'am.
asking, ha. So when you write these complaints, the earlier part is written well. Only thing with the complaints, irritability, angry, abusive behavior, rather if we mention in form of the criteria which the person is meeting. So I
Okay.
believe 4 to
Yes,
5
ma'am.
criteria are meeting. So you could write it in terms of those criteria after stopping the medication because of demise of his cousin. And the important thing what sir was also saying, the genetic predisposition and the other factors, the adaptability and all, can be included under the 4 Ps with the like they could mention with the predisposing factors being, with the perpetual factors being. So
Yes,
that
ma'am.
way it could be written down.
So there is one more question in chat box to the experts. Where should the 4P model be ideally mentioned, at the last or in the earlier part of this diagnostic formulation?
It should be in the diagnostic formulation. Even we can start with the history with the predisposing and precipitating factor, which already she has mentioned that he has stopped medication because of some reason and then he has a complaint. So that we can mention in the earlier part also and in the diagnostic formulation also.
Yes, sir. Maithili ma'am.
Yeah, we can start mention in the earlier part, like when you're saying about the social demographic, where brought by family members with the 4 factors being as follows, or the way she has presented now, I liked it better that way, in which she's mentioned everything, because there were a lot of factors in the 4 Ps to be mentioned, to be added in the beginning.
Yes, ma'am.
So in this case, I would prefer that she would go through the way she has said, with the current symptoms, the past history of one manic episode, depressive episode, and the 4 Ps, the factors being this so and so. So yes, for me towards the end, for this specific case, if you would ask, but again, if there is no fixed formula, it could be said in the beginning. I just suggested towards the end because there were many factors to be said.
Thank you, ma'am. Thank you, sir. So the next question is by Dr. Saranda. I would slightly reformulate the question. What would be the difference between a diagnostic summary and diagnostic formulation?
Yeah, it is very good question. Diagnostic formulation is generally we go with the neurotic patient like hysterical or somatoform conversion or anxiety, phobia, in which what I said we have to try to find out all the patients different what we said defense mechanism, is current status, is ego strength, is affair, is interpersonal relationship level, everything can be there in diagnostic formulation. What she has mentioned is like a diagnostic summary. So in psychotic patient, we can be happy with diagnostic summary when we say it is like a mania or schizophrenia. But when we are talking about a patient who is having episodes of unresponsiveness, or we can talk about phobic patient or OCD patient, then the diagnostic formulation makes a very good sense. Then we can go through all the details about that.
Maithili, ma'am.
Yes, it's a very good question. Those are diagnostic summary and a formulation are essentially to be understood. These are two completely different things. A diagnostic summary is more of you're summarizing the entire case. So diagnostic summary is something that we would normally write, say, on a discharge card, where we are mentioning what were the current symptoms, what were the past symptoms, and we have summarized the case in general. Whereas in diagnostic formulation, we are looking at from a bird's eye view, where we are seeing not just about making a diagnosis, but also trying to understand what could be the factors which have led to the illness. Like say the 4 Ps which I mentioned, like what are the factors we have which have predisposed. Now, like in this case, it is clear that the person is having bipolar mood disorder. So in a diagnostic summary, we would be saying about whatever factors are there in the of this illness in this patient. But when we are talking about diagnostic formulation, we are also understanding what are the factors like predisposing factors and other factors which have contributed. And it also should mention, say, a differential diagnosis, overall a treatment plan, both in terms of the psychological aspects, also in terms of medication which has to be given. So these are two essentially different things. A diagnostic formulation is more of processing of the data which is there in the diagnostic summary. We expect a resident that after seeing a case should not just be able to take the history and present and make a diagnosis, but also look at it from a more holistic point of view. So it's no more a patient, you are try to understand him as a person.
Thank
Yeah,
you,
it
sir.
can
Thank you,
include the
ma'am.
personality traits also, whatever different
Oh,
things,
yes, sir.
impulsivity and other things. Yeah.
Shilpa ma'am, any comments?
No, I agree with both of them. I think Maithili put it pretty concisely that these are two different things, and how it has a more diagnostic formulation has a more holistic approach. So at the end of it, you're not only establishing a diagnosis, but you're looking at the whole person and what you will plan for that person next. Besides just the medications, the other psychosocial interventions also.
Thank you, ma'am. If I may be permitted, I would like to extend one question in continuation to the last one.
Yes.
So, sir, ma'am, question is to all my seniors and teachers. Sometimes we see different formulations like psychoanalytic formulation, CBT formulation. How do we compare that to diagnostic formulation? Are they same thing for different schools or are they separate thing?
I understand that if we go through that, we generally as a resident level, when we talking about that PG level, there is a one formulation we used to say psychodynamic formulation.
Yes, sir.
Psychoanalytic and cognitive approach, and that is very specific. It should be when you are well trained with that modality of treatment, what you are trying to approach. Otherwise, psychodynamic formulation encompass all type of things. What we are talking about, like cognitive distortion, if we are talking about, or if we are talking about the primary conflict, or ego strength, or defenses, or some other secondary gains, or everything can be mentioned there. And that's why I said the diagnostic summary is good for psychotic patient, but diagnostic formulation in depth is a requirement in a case of a, what we say a general way of this neurotic, or what we say phobia, or hysterical patients, what we are talking about.
Thank you, sir. Maithili, ma'am.
Yes, again, what as you're saying, these are also a part of diagnostic formulation only, but specific type of formulations you would mention as the case demand. Like say in a case of a convergent disorder, uh, or a dissociative illness, there would you would prefer something more of a psychodynamic aspect. It depends on the case how you would go about. In the current case which is presented by the resident, how what is presented currently is the right way to go about.
Thank you, ma'am. Shilpa, ma'am.
Yeah, I agree that the current patient who's bipolar 1 disorder, this is the way to go, except that she has to refine it a bit, as
Yes, ma'am.
both the experts have mentioned. But psychodynamic would be more in other cases where we require to go more deep to understand the patient and the relation with the symptoms.
Ma'am, we have one more question from Dr. Harshit. If we are mentioning predisposing factors in diagnostic formulation, do we also have to mention past history of episodes just then, and later after precipitating factor should mention current complaints and episode? If I can understand correctly, he wants to ask whether we go first presenting episode and then past history, or we go longitudinal.
See, there are two ways. If we go with the UK way, then they go with the continuous thing, like what first episode start with that. But as a what we taught like American as a group of association, they go with the present illness and then they mention the past illness. That is a two different approach altogether. Both
Yes,
are
sir.
good if we are putting in a right frame.
Maithili, ma'am.
Yes, both approaches are good. Sometimes the students can try to choose the one which suits the case better. Like say in this case where the current episode is mania and there were past episodes of mania as well as depression. In this case, it makes sense going with the present illness first and then talking about the past illness. But say it is an ongoing factor to it, then I would prefer a longitudinal course where you start from the beginning.
Thank you, ma'am. Thank you, sir. So I guess this concludes our first case presentation. I would stop my screen share here, and I would
Yeah,
invite.
we all say thank you very much to Dr. Neha for a good presentation. Yeah.
Thank you, sir. Thank you, ma'am.
Welcome.
So our next presentation is about the examination and investigation part. For the sake of brevity, it was mentioned as management, but the primary focus would be on these two. I invite our experts to introduce the topic in little more detail as to what is expected from the students.
Yeah, Dr. Trichinda. She is from Goa, I think so.
Yes,
Yeah, yeah. So it is okay. She should mention very briefly the history part, but more importantly, what she has, we try to understand the physical examination, the investigation, what is required in this patient, and ultimately the management part. The three things should be focused more.
yes, sir.
Dr.
Yes.
Tresenda,
So,
are you there?
Yes,
Yes,
yeah,
yes, ma'am.
I'll be handing
Yes.
over the moderation part. Yes, sir.
Yes, you can start, Dr. Trichinda.
So
Uh,
I'll be handing over the moderation part to Dr. Sharanda.
Thank you, sir.
I
Thank
have
you.
started the screen share.
Yeah, I have started the screen share. Is it visible?
Okay,
Is my
okay,
screen-
sure.
Is my screen visible? Is the slide
Yes,
visible?
visible.
Okay. Mathli ma'am, you were saying something. Sorry, we interrupted you. You were saying something.
Yes, I would like to add that what is expected. The thing is that in most of our cases, there wouldn't be much in the physical examination. But since we also have cases like in this case, which like there is some neurological thing is suspected, or there could be some other comorbidities, then the physical examination has to be thorough. Very often, we do see that there are patients with mental illnesses who would not complain about any symptom. So we should not take it just by hearsay value. And even though a case is just a purely psychotic case or has mania or is depressed, the physical examination should be conducted thoroughly.
Yes, ma'am. Yes, ma'am. So firstly, I would like to thank our experts, Dr. Nimeshwar and Mathli ma'am. The last case was very helpful even to me, and the questions, diagnostic formulation and summary has been a very confusing question to me for a very long time, and was very well like clarified for me also. And not wasting too much time, let us continue with the second case. Tresenda, I'll be sharing the screen and I'll change the slides for you.
Yes, ma'am. Yes, ma'am. So going through the brief history, I will be talking about a 32-year-old male who has been consuming alcohol since the last 6 years with regular intake since the total duration of illness is 11 years with regular use of alcohol since the last 6 years. Average amount of alcohol use per day was 2 quarters of whiskey, last intake being 3 days back. Patient presented with symptoms of tremors since 2 days, sleep disturbances and loss of appetite since 1 month, and generalized tonic-clonic movements of the limbs since 3 days. On general examination, the temperature was 37 degrees Celsius, pulse of 91 beats per minute, equal bilateral, normal in volume. The BP was 118 by 76 millimeters of mercury on the right brachial artery. Random blood sugar levels were 118 milligram percent. Uh, Blood saturation was 99% at room air. Height of the patient was 1.5 meters and weight of 45 kilos with a BMI of 18.5, which falls in the underweight category. There are multiple tattoos on bilateral arms and right forearm with green ink, largest measuring around 20 by 10 centimeters. There are hypopigmented patches on bilateral arms, back, and chest. The the hair of the patient is normal in color and distribution. Next slide. Nutrition, the patient is lean built, averagely nourished, no pallor, icterus, cyanosis, lymphadenopathy, grade 2 clubbing, which is present on bilateral fingers, no edema, vertebral column joints, there is no abnormality noted. Mouth, there is glossitis of the tongue. Teeth is normal dentition with nicotine staining of teeth. Neck, there is no abnormal pulsation, swelling, and thyroid gland is normal. Per abdomen examination on inspection, the shape is normal. Umbilicus is central inverted. Abdomen moves with respiration. There are no abnormal pulsations or dilated veins. On palpation, there is minimal tenderness noted in the periumbilical and the epigastric region. There is no guarding or rigidity. The liver is palpable 3 finger breadths below the right costal margin, which is firm to touch and the margins are regular. The spleen and age and the kidney was not palpable. On percussion, there is no evidence of free fluid in the abdomen. On auscultation, bowel sounds are present. On respiratory and CVS examination, on inspection, the shape and movements of chest are normal. With respiration, the apex beat is visible in the fifth intercostal space, 6 centimeters from the left costal margin. There are no dilated veins or scars or sinuses. On palpation, the trachea is central. There is no abnormal mass. The apex beat is palpable in the left fifth intercostal space. On percussion, the bilateral resonant sounds are heard. Cardiac dullness is present on the left side. On auscultations, breath sounds are vesicular, no added sounds. Heart sounds S1 and S2 heard. There are no murmurs or any abnormal heart sounds. On the CNS examination, starting with the cranial nerves, the olfactory nerve, the patient can smell, identify, and differentiate various odors. Optic nerve, the visual acuity, normal near and distant vision using the Jaggers and the Snellen's chart, respectively. Visual fields is normal by confrontation method. The fundus examination shows no evidence of papilledema. The oculomotor, trochlear, and abducens nerves. Pupils are normal in size, shape, bilateral, equal, reactive to light, direct and consensual light reflex is present. Accommodation reflex is normal, equal bilaterally. Ocular movements are full range, non-restricted. There is horizontal nystagmus which is present, which is jerky. Trigeminal nerve, the superficial skin sensations are normal. Corneal conjunctival reflex is bilateral brilling present. The motor component of trigeminal nerve, there is normal movements of jaw and jaw jerk is present. The facial nerve, the motor component, there is normal movement of muscles of facial expression. Nasolabial fold is present on both sides. Wrinkles on forehead present. Taste, patient can identify various tastes. Vestibular cochlear, hearing test, Reni's shows air conduction, which is better than bone conduction in both the ears. Weber's, the sound is audible in both ears equally. Glossopharyngeal and vagus nerve, the motor component, the uvula is central and movement of palatal arches is normal. The sensory touch sensation and taste sensation on the posterior 1/3 of the tongue and pharynx and gag reflex is present. Spinal accessory, the sternocleidomastoid, which includes movement of head side to side against resistance and lifting the head off the surface is normal bilaterally. Trapezius is shrugging of shoulders against resistance is equal bilaterally. The hypoglossal nerve, tongue, which is basically observation of the tongue on the floor of mouth. The size is normal. There is no abnormal movements noted. And on protrusion, the movement of tongue is within normal. Sensory system, pain, touch, and temperature, which is found to be normal on the face, neck, trunk, buttocks, upper limbs, thighs, legs, dorsum of the foot. However, there is decreased sensation of light touch on the plantar aspect of bilateral feet. Proprioception, position sense, passive movement, and vibration sense are all within normal limits. Stereognosis and graphesthesia. Patient was able to recognize objects by the feel of its shape and size. 2-point discrimination, which is noted to be decreased on the plantar surface of bilateral feet, which was found to be 2 centimeters. Graphesthesia, patient can identify alphabets traced on the skins on the palm, forearm, and thighs. Motor system, muscle mass is equal and comparable on both limbs. Muscle tone is normal and comparable in both limbs. Power is grade 5 by 5 at all joints in bilateral upper and lower limbs. The posture, stance, and the gait of the patient is normal. Equilibrium is maintained. A Romberg sign is positive. Swaying at the ankles was noted. Ataxic gait was noted. Involuntary movement, postural tremors, fine tremors on bilateral outstretched hands is present. Reflexes, deep reflexes of biceps, triceps, supinata, and ankle is +2 on both sides, and ankle is +1 on both sides. Superficial reflexes, abdominal reflex is muscles in all quadrants stimulated and contract. Plantars are flexors bilaterally. Glabella tap, sucking reflex, and grass reflexes are absent. Going to the higher function, the patient is calm, conscious, cooperative, sitting calmly, oriented to time, place, person. Attention was aroused and concentration was maintained. A patient is able to obey command, maintain eye-to-eye contact, rapport was well established. Intelligence was found to be average clinically. Memory, remote, recent, and immediate was intact. So the blood investigations I would like to do in this patient would be a complete blood count to rule out any anemia or infection, which includes hemoglobin, total count, differential count, platelet count, packed cell volume, MCV, then renal function test for blood urea and serum creatinine levels, serum electrolytes like sodium, potassium, and chloride, and uric acid. Liver function test to rule out any hepatic dysfunctions, serum bilirubin, which is total direct and indirect levels, total proteins, albumin globulin ratio, SGOT, SGPT levels, alkaline phosphatase levels, gamma glutamyl transferase levels, uh, carbohydrate deficient transferrin to which is used as a marker for heavy drinking and abstinence, serum amylase and lipase to rule out pancreatitis since there was tenderness in the epigastric and periumbilical region. Serum lipids, which includes total cholesterol, triglycerides, HDL, LDL, and VLDL. Radiological investigations would include ultrasound of the abdomen to see for any pancreatitis, hepatitis, fatty liver, and free fluid in the abdomen. CT brain to look for any infections or intracranial bleed, and ECG examination to rule out any arrhythmia secondary to electrolyte disturbances. The treatment would include, I would like to offer admission to the patient under section 89 as high support needs to assess the severity of alcohol using the CVAR score, in which less than 8 suggests mild and more than 15 suggest increased risk of confusion and seizures. Forementioned blood investigations, monitoring of vitals, which includes pulse, BP, and SpO2, correction of the fluid electrolyte imbalance by adequate hydration or IV fluids. Injection thiamine would be started for the patient, which is 500 milligrams diluted in 50 to 100 mLs of normal saline, infused over 30 minutes, 3 times a day for 3 days, followed by oral thiamine 100 to 300 milligrams. for a duration of 3 months after test dose. Benzodiazepines, which fixed dose regime would be used, which includes lorazepam at 8 to 10 milligrams divided in 3 doses at 2 milligrams, 2 milligrams, 4 milligrams, which is gradually tapered over 7 days. Injection diazepam at 5 or 10 milligrams or lorazepam 4 milligrams if the patient becomes restless. Physical restraint if the patient gets restless after consent from the nominated representative. Injection ondansetron 4 milligrams intravenous 8 hourly. An injection pantoprazole 40 milligrams IV 8 hourly for a duration of 5 days. Tab ursodeoxycholic acid at 150 milligrams twice a day. And tab antispasmodic like Buscopan if the patient complains of abdominal pain. And patient would be receiving adequate nutrition. Long-term management includes motivation enhancement therapy and the use of deterrent agents like disulfiram, which could be initiated after written informed consent from the patient and the relative at a dose of 250 milligrams once a day or twice a day. Other options that are available are anti-craving agents like acamprosate and naltrexone. Topiramate, baclofen, and SSRIs can also be considered.
Are we done, Tracinda?
Yes, ma'am. Yeah,
Uh,
I'm done.
So I would like to open it for discussion. I would invite Dr. Parikh sir to please ask question. Sir, you are muted, sir.
So it is Dr. Pinto. It is very nice presentation and very detailed neurological and physical examination. It is very good for all the residents to see. It is very well mentioned different things. The only thing that it cannot be done practically in a exam for 45 minutes to 1 hour to cover this all. But as a case presentation in the ward side, we can have this time and we can mention. So it is very good, but we cannot put that as a exam presentation. We cannot do it in 1 hour. Any resident can do it. So that is good. A few things which we would like to mention here, that she has mentioned generalized tonic clonic movement of the limb, 3 days, and that is what episodes is last for, about how much time, and it is frequencies once a day or twice a day or more than that, and there is any delirium associated with that or not. That is very important. She may be mentioning it is like a delirium tremens, or it is a severe case of withdrawal, what we understand from the tonic-clonic convulsion and the tremors. But it is not very clearly specified that it is severe enough or not. So that if she can add, that will be a good thing. Then in
Yes, sir.
next, yeah, then next she has mentioned very well about the neurological part. Only thing we understand in alcoholic patient, we required a cerebellar signs to investigate, cerebellar function to investigate. You have mentioned in posture one or two things like a Romberg sign positive, but you have not mentioned all the cerebellar things which should be mentioned in alcoholic patient, because there is a possibility of cerebellar degeneration or vermis or other things. So we have to see what different cerebellar symptom things she has investigated, try to examine, and what is positive in this patient. Understand, Dr. Pinto?
Yes, sir. Yes, sir.
Yeah, so that is, otherwise you have done very good neurological things except the cerebellar functioning. And the management part, what the investigation part, I think everything is mentioned well. It is well detailed. If we go through the in a private setup, it is very huge amount patient has to spend for all this thing. But in an academic institution, it is okay if it is free. One thing we want to add, that most of the alcoholic, what you said is weight is 45 and his BMI is less, then there may be all vitamin deficiency, which you have not tried to understand or try to investigate, like B6, B12, and other things. which is generally there in this type of patient. So we should try to investigate for the other vitamins other than vitamin B1, because there is also deficiency of pyramid, there is also deficiency of folic acid, because you said the tongue is also glossitis is there, and so that should be mentioned here in investigation if possible, and we should do that to understand that what other vitamins are also deficient, like B12 or B6 or not, or that. And
Yes,
then
sir.
in treatment part also, if we go through that same. So here also we want not only thiamine. It is good we have to give thiamine, but we have to give the multivitamins. All the vitamin B, 12, B6, B9, everything should be like what we are giving in our way, Optineuron or like that, which covers all the vitamin B. So that patient will be, there are most of the times they have a pellagra also, they have a other deficiency also. And by correcting one thiamine only, we cannot cover the all the B spectrum of the vitamin B. So that is important. I think we can mention that in the treatment part. Okay,
Yes,
and
sir.
you also you should mention here that if patient has a convulsion, what you mentioned in the history, then for that you have to give injectable straight, means you have to give either lorazepam or diazepam as a straight injection, rather than we can go with the oral tablets in that type of patient.
Yes, sir.
Okay, so that is what a brief thing which we can add in this beautiful presentation. It is very good, and congratulate for this very detailed and comprehensive presentation.
Thank you, sir.
Umate ma'am?
Yes, Dr. Pinto, very nice presentation. You have examined thoroughly. Only thing that I would say that in case of a person with alcohol use disorder, in this case, I would also recommend like the cerebellum examination was missing, especially if you have a Romberg sign. And secondly, it could be a simple examination of fundus. So it is very important in, especially in patients of alcohol, where fundus examination you should do. It doesn't take much time. But I must say, if this comes really as a long case, it is not a long psychiatry case. It is just not possible to have such a thorough physical or a neurological examination, in which case it is much more brief. But even in the brief physical examination, if it is an alcohol case as a long case, fundus examination you should do along with especially the reflexes. So overall, yeah, this all is good. Even the management part is good. Only thing I will recommend, if you are presenting it as a case for treatment, you should mention what exactly you would give. Like rather than saying you would give diazepam or lorazepam injectable if the patient is restless, it would be better if you would say what you would exactly give, diazepam or
Yeah.
lorazepam. So
Yes,
if you got
yes,
to the
yes.
point, that would be better. Similarly, for long-term management, the second slide also, if there are, of course, it's good you have explained that there are so many options available, but it is better if you, while presenting, you would say that this is your case and this is how you would want to manage. One more thing I would want to say, when you presented the first slide of the chief complaints, this person has this tonic-clonic movements for 3 days, along with the last consumption was also 3 days.
Yes, ma'am.
back. So this is not going ideally on the lines of a delirium tremens. It seems like an ongoing process. So in such a case, if you would have as a long case for a alcohol use disorder, then a thorough neurological examination is must, because the person is having these tonic-clonic movements. Otherwise, in usual alcohol use disorder, a shorter examination would suffice.
Yes, ma'am.
Shilpa ma'am, would you like to say give any input?
Most of the points are covered by Dr. Parikh and Dr. Maithili. But I had seen these few points that last intake 3 days back and generalized tonic-clonic movements. So I don't know whether she means seizures and whether she means withdrawal seizures. So, it should be elaborated a little more. And also, in the this has to reflect in the management part. In the management, nothing about this has come. So it just mentions injection diazepam or lorazepam if patient is restless. So you would actually give injection diazepam IV stat if there is a seizure, which you might expect because uh, these seizures come in a flurry. So they would come more if there is history. Also, I think in the examination, there was loss of sensations in uh, in the feet, I think.
Yes, ma'am.
So, as I think Dr. Parikh mentioned about other vitamins, so in investigations as well as in management, that should reflect. So that because peripheral neuropathy is very common, so vitamin B12 levels as well as injection vitamin B12 if it is very severe, otherwise at least oral vitamins has to come there. But otherwise, overall, I think it's a very, very well done examination. I mean, the brief is like uh, properly taken, and investigations and examination is very thorough. So I think a very job well done, but just these few points you have to remember. Thanks.
Yes, yes, ma'am. Thank you, ma'am.
Are there any queries from the okay, Nachiketa sir has asked, is there any way to do neuro examination rapidly or in short time?
It is only practice that makes you to go with the faster way of neurological examination and relevant to that. Like alcoholic patient, very important is the you have to go with the cerebellar functioning basically because they have a most likely to have a finger nose test problem, Romberg test, ataxic gait, and other things along with the consciousness. So we have to go more with that. No, we cannot find anything like muscles and cranial nerves much involved with that type of things. So we have to see each patient with the experience. We learn that what area we should look forward more in that patient.
Ma'am, Matthew, ma'am, anything?
Yes, but then it will always be like how much short should we go? See, the basic physical examination has to be conducted. Uh, uh, I mean, it is a very essential for any case. Whenever we are seeing a basic physical examination has to be there. Neurological, as sir is saying, depending on case wise. Like in this case, if there is the person is having alcohol use disorder, then cerebellum, even a fundus examination, the reflexes, it's very common to have neuropathies. So you could see for any change in sensation. So depending on the case, you could do the examination which is most relevant.
Thank you, ma'am. Anybody else would like to add on to this? Shilpa ma'am, Neena ma'am is also here. Anybody?
No, I think Dr. Maithili just said it rightly. I agree with her that it depends on the relevance in that case. So in this case, you have to do cerebellar, you have to do sensory examination. There is no, if you have not done, then there is a problem. But if you did not do cranial nerves, it's fine if it is not relevant. But if you did not do cerebellar or sensory or fundus or reflexes, etc., which are relevant, then it will be a problem.
Thank you very much, ma'am. There is a question in the chat box by Dr. Gautam. He is asking if there are pelagorogenic changes, a dermat consult could be considered. Sir.
I think we can have, if we have a facility in the freely patient can access that, it is best. But otherwise, we can give the multivitamins and that we can try to see the patient for acute phase over. And then if it persists, then we can send to the dermatologist. It is not that it is must to send for. If it is severe enough, then all okay.
Thank you, sir. Ma'am?
Yes, only if required, you should have the setup and everything. Already the investigations ordered itself are quite a bit.
Yes.
Yes, ma'am. Any other questions from the audience? Okay. I don't think there are any other questions. Dr. Neena ma'am messaged in between that both the cases have been very well presented. Thank you, ma'am, on behalf of both the residents, I would say. And also, we've shared a feedback form in the chat box. I request everybody to fill it up. It will help us understand what topics will be helpful for you, and we can conduct sessions on basis of that in the next sessions. I would like to thank Dr. Parikh sir and Dr. Maithili ma'am for being experts in this session. Both the topics are very important, and these topics were chosen because usually we don't pay attention to it, and these are actually very important, and there's a lot of confusion with respect to both of these, what should be mentioned, what not should be mentioned, and there were very potent queries like what all examinations we have to mention, and management also, and of course the diagnostic formulation case was also very important, and it was helpful to like people like me also. So I hope there were around 100 people in the first case, so I hope all the residents have benefited from it. Anything, sir, ma'am, you would like to say?
No, it is a good presentation, very well tried, and we think that we every resident can learn from that. So thank you, Dr. Shilpa and whole team, Dr. Saranda, Dr. Nachiketa, for good efforts, and thank you for that too. Resident also, we have a claps for that. Yeah, that's good presentation.
Yes, 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 yes. I would like to thank both the residents because it takes a lot of courage to speak in front of so many people, and it's always a good learning process. Ma'am, would you like to say something, Natlina?
Yes, excellent presentation by both the residents. And I would especially like to thank the IPS West Zone team for organizing such programs which are helpful for postgraduate students.
Thank you, ma'am. So we have a short session of quiz also after this, which will be conducted by Dr. Ashish Srivastava sir, who is assistant professor in the same college as Trasinda, Goa, Institute of Behavior Sciences, Goa. योगेंद्र भाई चैट में पोल पोस्ट कर दीजिए प्लीज.
Yes, ma'am.
हाँ. So the questions have appeared in the poll. We request everybody to please answer.
We'll keep a limit of a minute or 45 seconds for a question. We scroll down after that. Yeah.
Okay, sir.
I think, Saranda,
जी sir.
we have not displayed the case.
Yes,
Can you
sir.
pause this?
Okay.
Can you pause this?
योगेंद्र
Yeah,
भाई
I think
pause
there's
करिए
no
इसको.
case. The question is based on the case, right?
Yeah.
हाँ.
So I will end the poll. I will end
Can
the
we
poll.
restart?
हाँ हाँ.
You
मैं
can restart the poll.
Yeah.
Okay. Okay. Exit out and restart. Yes.
I end the poll.
Yeah. Please restart when we say. Yeah, Sharanda, can you share your screen and
Yes, sir.
put up
Yes,
the
sir.
PPT, please?
Yes, sir. Yes, sir.
Before the crowd
Yes.
vanishes.
Yes, sir. Sorry. Yes, sir. Yes, sir.
Mr. Yogen, can you? Okay. Okay.
Is the screen visible?
No.
Oh, I can see it. The screen
It
is
is
not
visible.
okay.
You can see the case? I cannot. Okay. No problem.
We can just see your desktop.
Yeah, not the case.
Double click.
You,
Okay, wait, I'll share it again. I'm so sorry. Is it visible now, the question?
yeah, now it's visible. Yes.
Okay, sorry, sir.
Yeah, just keep it for a minute.
Yes.
Everybody reads it and then we go to the poll. Yeah.
Yes.
It's a 38-year-old female with a history of alcohol use disorder for a long time, presents with complaints of persistent cognitive difficulties and visual disturbances. On physical examination, ataxia, nystagmus, and impaired cognition is elicited, including the mental status. The patient denies recent alcohol use but reports prolonged use of heavy drinking in the recent past, and the liver functions are within normal limits. Very straightforward case, commonly seen in our practice. Yeah. Now we can go for the poll with this background.
योगेंद्र भाई पोल डाल
Yes,
दीजिए
yes, madam.
हाँ
Yes. Okay, we can go to the next one.
Okay.
I think all should participate. Other than the students, I think we will also participate in this.
No, ma'am, I think so. Co-host cannot participate, cannot answer.
Hmm?
Co-host cannot answer. Can you
Yeah,
answer it?
no
Yes.
okay. Okay. I can't answer it. So only
The host.
8% people have participated. Only 5 out of 58.
Yeah, we'll request everybody to participate who is not the host.
I think there's only first question that is seen.
We have to scroll down, ma'am.
Yeah, but the poll is
People-
gone.
Something happened.
Yes,
People
yes,
are saying it's
trying to
not
answer.
working.
Closed down suddenly.
I can
You can
see.
restart the poll, Yogen.
Restart.
Yeah, it's got stuck. People are not able to answer.
No, there is no poll that's gone from the screen.
हाँ वो बंद हो गया.
I can see
Yeah,
it.
I
ma'am.
relaunched it.
I
can
can
see.
also see, but I think many
now
are
it
not
has
able to
come.
see.
Now it
Came
has
now.
come.
Okay.
Okay, restart.
Yeah, I relaunched.
Audience, please.
Answers are coming in.
Participation has further gone down. Anyway, scroll through. I think, yeah.
I'm requesting all the residents to please participate. These questions are very important and helpful, interesting questions.
Participation is increasing. Thank you.
Can someone clarify question 6? Because in the poll it just says untitled question, choice 1, choice 2. So is there a
Yeah,
question?
there is no question there.
Yeah.
Let's check.
So, Anda, can you,
Ji sir, I'll look into
you
it.
can slide down your slides.
Is it moving? I can't see my screen.
No, it's not moving. I think it's frozen because of the poll. Can we
Yeah.
scroll down the poll? I cannot see any moving the poll.
It is moving, sir. Yes, I am able to scroll it down.
Okay. Okay, that's good.
Because of the poll.
Moving now. Your
Just
slide.
before
Okay.
this, before that,
that.
Sandra.
Now the share screen ended.
Oh, okay. Very bad.
Yeah, that slide 6.
Is visible?
We can see PowerPoint.
Not the
We can
slide.
go to slide 6. It is 5 as of now.
Oh, okay. Wait. My laptop is. How do we? Okay.
Yeah, the
Yes.
term kindling.
Yeah.
Yes.
Is it visible now?
Now it is visible.
No,
the-
question number 6 is not visible to
What
me.
is the question after kindling?
Yeah,
This is the
yeah,
kindling question. After this,
the last question. Medication.
Then there are
so
only
there
6
is no.
questions. There has been a
Okay.
slight error.
So there is no question 6. No?
No question 6.
Question 6 is not there only. Yeah.
So far, 34 people out of 52 have participated.
We'll just wait for a minute and I think then we'll just wrap it up. Okay. Okay, Sharanda, can you slide your slides? Okay,
First
no
question.
problem. Question can be seen here also. That's all.
Yes, sir.
Yeah, leave it like that. Anybody wants to answer? Last 10 seconds. Okay, Sharanda, I think we can close the poll. Yeah.
I can't see the poll.
I close the poll. End the poll.
Okay.
I will share the result now.
Please share it with me.
Okay. That's okay. Yeah, keep the case. We'll
Yes.
go slide by slide. Sharanda,
Yes, sir.
if you see, this is a young lady who has come with cognitive difficulties and visual disturbances. There is ataxia, nystagmus, and cognitive difficulties. So next slide. Okay. What is suspected of acute presentation? This is a very clear case of vitamin B1 deficiency. Okay, which presents with nystagmus, ataxia, and leading to Wernicke's complex. And if later on not prevented, Korsakoff. Somebody has answered B12. I think B12 deficiency leads to sensory neuropathies and those kind of symptoms rather than cognitive and nystagmus symptoms. So that is very clear. Hippocampal degeneration, again, will be a long-standing deficits, not an acute onset of symptoms. Lacunar infarct, again, a very acute presentation with other weaknesses of the, certain areas or certain other deficits specific to that areas. Next question. What brain is commonly affected and explains ataxia? I think most of them have answered this question correct. It is cerebellum. Next question. Which structural abnormalities might be most commonly? The word here catch question is most commonly expected on a MRI scan to correlate with the cognitive changes. I'm not sure. I have not got the poll. We'll see later, but I'll give you the answers. Yes, the most important is frontal lobe degeneration followed by cerebellum. And rarely mammillary body damages is seen in very few patients. The most important is the frontal lobe degeneration, that is cortical degeneration, is responsible for cognitive changes. Next. What percentage of patients with chronic alcohol use develop Wernicke's Korsakoffs? Despite all the awareness that we have and despite good care that we institute B1 early, as Tracenda said, still around 10 to 20%. So answer will be second, 15 to 20%. 10 to 20% of the people still get Wernicke's Korsakoff syndrome in severe alcohol or chronic alcohol use. Next. The term kindling in context of alcohol withdrawal refers to, it's a process which produces worsening. So increased sensitivity of the cortical, especially the neurobehavioral symptoms of withdrawal, they get accentuated with each withdrawal episode next time. That is the process of kindling in withdrawal symptoms. Next. Which medication, the last question, has been identified as potential treatment of AUDs based on kappa opioid receptors? Naltrexone, many may have answered, but naltrexone, remember, acts through mu receptor, and the kappa opioid receptors now included in the national guideline by US is namilefine, which has been recommended which acts through kappa opioid receptors. We do not have much availability in India to use it, but yes, in the West it's being used. So that's the end of questions. I would have benefited. And Sharanda, if you are saying, or I must congratulate the last time's people.
Whatever you say.
Sharanda, you have the names.
Yes,
Yeah, go
yes,
ahead.
I have. Yeah. So I have the names of the last session's quiz winners. Last session was on 12th of December. So the top three with all 10 questions right were Dr. Rushikesh, Dr. Hetvi Shah, and Dr. Shekhar. Congratulations to the three of you. And there are other who scored 9. They were Dr. Kinjal Andrade, Dhwani Parekh, Disha Patel, Janvi, Mary, Dhanvi M, Pratna Rathod, and Tanvi Google. Congratulations, everybody.
Well done, well done. This is great. 9 on 10, no, 10 on 10 is very good.
And we've got the results of this quiz also, sir. I have shared the Excel sheet with you, although it's not very clear. But
I think we'll have to do our maths to give next time, Anna. It's too complicated for me
yes,
to
sir.
read up.
Yes, sir. Yes, sir. We'll
Okay.
share
I
the.
think that question, naltrexone, the last question, tricky. I think everybody has answered naltrexone. I've not seen a single correct answer in nalmefene when I'm glazing through it. So it is namilefene. One somebody has
There are
given it
5.
right.
Dr.
Oh, yeah, 3, 4. Yeah, now I get it. There are 3, 4 Nirmal Shah and all. Okay, so that's good. It acts through the disulfiram, as of it's a deterrent drug, and topiramate through the GABA receptors. So thank you everybody for good participation at the end also. Thank you. Thank you, sir.
Thank you, sir. Thank you so much. And thank you everybody for participating, and see you in the next session. Would anybody like to say anything? Maithili ma'am, Shilpa ma'am, Parik sir has left.
Thank you,
So excellent.
Nachiketa and Saranda,
Thank
for
you.
moderating the sessions. Thank you, Dr. Ashish, for your
Thank you, ma'am.
quiz inputs. And thank you, Dr. Parikh and Dr. Maithili once again. Thank you.
Yeah. Thank you to the whole team. Yeah.
Well done. It should go on. Yeah.